Good morning. It's a real pleasure to be here, to be invited to speak, and I'd like to thank Margaret and Paul and company for inviting me, and it's certainly a pleasure being back in your beautiful city. The balmy weather certainly has me feeling quite at home, but really it's great to be here, and also to visit this institute. I've certainly been enjoying reading the work that's come out of it for a very long time, and so it's great to be here. I have a lot of territory to cover, so I'm going to jump right in. Really what I want to do today is to talk to you about what happened in Vancouver. I want to tell you a bit of a story, and in doing so I'm going to describe a public health emergency that was declared, but also the response to it. And in doing so I want to share with you some of our successes, but also some of our failures, and how we tried to address that to eventually end up with what I think is a fairly effective response, really rooted in a fairly balanced approach to problematic drug use. First, let me introduce you to the downtown Eastside. I'm sure many of you heard about it. It is Canada's poorest urban postal code. It is the home to an estimated 5,000 people who use illicit drugs, primarily injectors. They live in a 10-block area. There is a massive open drug market, which you can see here. But also importantly, there is a large network of alleyways that operate behind the single-room occupancy hotels and the shops. And really, this became an open-air injecting environment. People would use the little injecting niches, the doorways behind the shops, to inject, so that when the police would pull up at the end of the alley to see if people were in there misbehaving, they couldn't be seen. But I'm sure you could understand this really made for some horrific injecting conditions. Also very important to the Vancouver epidemic is the network of single-room occupancy hotels. These were originally developed to accommodate individuals working in the resource-based economies, such as forestry, who would come out of the bush after working for weeks on end. They wanted cheap accommodations for just a night or two, and accordingly there were taverns on the main floor, an active sex work industry. When those resource-based economies dried up, this really became housing for the urban poor, but also during the 80s, when there was a lot of nice language around deinstitutionalizing the mentally ill, they were promised community care. The community care never happened, and so they ended up living in the downtown East Side. And these hotels are famous for their horrible conditions. Fortunately, increasingly, they've been taken over by NGOs and Housing First programs, and they're gradually getting improved. In 1997, we experienced what has been described as the most explosive epidemic of HIV that's ever been observed in the developed world, with an annual incidence of about 19%. This was largely driven by the injection of powder cocaine, which had hit Vancouver. People were injecting up to 20, 30 times a day. A typical cocaine run would be 3 or 4 days without sleep, followed by 2 or 3 days of rest, and then going back out and starting all over again. There was also a massive situational unavailability of syringes, primarily because the syringe exchange had a number of deficiencies, which I'll talk about shortly, but it was also designed for a heroin using population, injecting 2 or 3 times a day. At the same time as we experienced that epidemic of HIV infection, the province of British Columbia was experiencing about 1 overdose death per day, and that's a province with around 4 million people. And this is a picture of an event called 1,000 Crosses, where the Vancouver Area Network of Drug Users, the drug user organization VANDU, erected 1,000 crosses in a park and invited people to come in and write the names of loved ones they had lost as a means of demanding action in response to this problem. Like many cities experiencing problematic drug use, the primary response has been enforcement of drug laws at the street level. And this has really gone on for decades, and for a long time the policy was one of containment. You can do that in the downtown East Side, but you can't do it elsewhere. So the combination of this active drug market, this open air injecting environment, everybody in these single room occupancy hotels, the containment by police made for a real public health disaster, but it also afforded some good opportunities for a public health response. The Regional Health Authority, in response to the overdose and HIV epidemic, declared a public health emergency. However, after a few years of inaction, the municipal government was quite progressive at that time, and they launched this document, the Framework for Action, a four-pillar approach to drug problems in Vancouver, which is modeled after the Swiss approach, whereby they're trying to seek some rational balance between prevention, treatment, enforcement, and harm reduction, which is a tricky thing to do, as I'll describe shortly. They held consultations throughout the city. They got the support of various stakeholders and moved forward. It was around this time that my colleague and I, Evan Wood, launched the Urban Health Research Initiative, and we've been responsible for evaluating many of the initiatives of the four-pillar approach. So I'm just going to take a moment and describe our program for you, as I'll be sharing lots of results from our work throughout this talk. Our flagship study is the Vancouver Injection Drug User Study. It's a prospective cohort of over 1,000 HIV-negative individuals who inject. It's in its 14th year. It's funded by the U.S. National Institutes of Health. We've enrolled and followed over 1,500 individuals. Although the median age is 39, a third of the cohort is now dead. We also, with funding from NIDA, are following the Access cohort, which is 1,000 drug users who use drugs other than cannabis, who are living with HIV. If you're in Vitus and you seroconvert, you move over to Access. We are also following over 500 street-involved drug-using youth in a separate but adjacent neighborhood called the ARISE study, the At-Risk Youth Study. And as part of the scientific evaluation of Eastside, Vancouver's supervised injection site, we have randomly selected and followed over 1,000 safe injection site users. The methods for all these cohorts are exactly the same. At baseline and semi-annually, people complete a very lengthy interviewer-administered questionnaire. They provide a blood sample for diagnostic testing, primarily of HIV and hepatitis C. And if you're HIV positive, we monitor your disease progression. Then people go on and complete a lengthy nurse-administered questionnaire about their health status. And in the province of British Columbia, everybody has a personal health number. And with people's informed consent, we're able to use those personal health numbers to link to a variety of databases to get ascertainment of various outcomes, including hospital utilization, admissions to addiction treatment. Now, we've built several layers under these studies, including a program of laboratory and basic science research. We have a fully funded and vibrant ethnographic social science program, and we've recently added a number of spatial methodologies, including GIS and qualitative mapping activities. We have a policy research and a knowledge transfer program. I'm not sure what the language you use is here, but we refer in Canada as, we talk about knowledge translation and transfer. That means translating research, knowledge gained from research into language that general audiences and policymakers can understand, and then finding ways to transfer that by creating things like policy briefs, plain research summaries, and trying to interact with a broader audience and trying to make sure we do something more than just populate the shelves of libraries. We also have an active community-based research program. All our community-based research studies are done in collaboration with drug user organizations in Vancouver. We have a number of studies with the Vancouver Area Network of Drug Users, and we also do similar work in Thailand. And we use this cohort infrastructure to support a number of clinical trials and intervention studies. So when the four pillars approach was launched,